Assalamu alaikum. On this presentation on surgical knots, we'll go through the structure of the surgical knot, how it's being built up, different types of knots, what make you choose a particular type of surgical knot, the 12 governing principles of knotting and tying, and special knots. The Encyclopedia of Knots have description for 1,400 different types of knots. The vast majority are used in agricultural, industrial, marine, and security purposes. We only need to know few of them for modern surgery. The basic unit of a knot is this, the half-reef knot. This is a single strand of suture with different coloring to its ends. So one end is colored red and the other is colored yellow, just for demonstrating the knot structure. And if you wrap one end of the suture on the other, then you get this basic unit. And all knots are formed out of a multiplication of this basic unit. So you can have a single wrap, double wrap, triple wrap, or whatever, and then you lock it the other way around and form another half reef knot. And you can do this several times, and this produces the several types of the knots. But the basic unit remains the same, wrapping one end of the suture material on the other to form the half reef knot. If the half-reef knot is the basic unit of knotting, a reef knot is the basic suture used in surgery, and is formed of two half-reef knots. You wrap one end of the suture on the other to form the first half-reef knot, and then reverse the direction and wrap it on the other end, and then you get the secure square knot. Mind you, the essential part of the square knot is the reverse of the direction. So as to produce this is the essential bit. The two ends coming out from the loop are the same color. And this applies whether you have started right or left. If you end up with the two colors coming out from the loop, the same side of the loop, either below or above, then this is a square knot. And it's secure because any tension on this end of the suture line is going to increase the interlocking. Whether the tension is applied on this side of the suture or the other, you will be pulling the same end through the closed loop of the other end, and this adds to the security of the knot. This is the basic surgical knot, the square knot. And the square knot is easy and very reliable, most reliable, and you can do it with two hands, you can do it with a single hand technique, or you do it with instruments, but the principle remains the same. You are doing two half reef knots, wrapping one end on the other and then reversing the direction and wrapping it on the other direction, so as to end up with the two colored ends coming out from the loop on one side of it, either below or above the loop. Now this is to illustrate how things can go wrong easily. If you are aiming to do the secure square knot, what you do is you wrap one end of the suture on the other to form the first half reef knot, and then you reverse direction and do the other half reef knot, and you end up with a secure square knot. And the way to do this is, if you take one end of the strand, the white end, you pass it below then above, then below the black strands. You cross your hands and reverse direction and do the same again to form the other half reef, below, above, and then below the other end. So you end up with a black loop and two white ends coming on the same side of the loop, either below or above the loop. And this type of knot is secure because if tension is applied on one side here, it's going to increase the interlocking of the white end of the strand within the black end of the strand, whether the tension is applied to this side or the other. But if you don't reverse your hand, you get the granny type of knot, which is unsecure and can slip. And it's easy to get into this if the hands are not reversed. Then you can have the white strand passing below, above, and below, and then above, below, and above. So the end product is that you have the white ends coming above and below the black loop, and the same applies to the white loop. You have the black strands coming below and above the white loop. So tension applied here or on the other side would end up in slipping the knot rather than securing it. A surgeon's knot is a little bit more secure than the square knot. There's only one single difference between the two. In the square knot, which is formed of two half reef knots, you wrap the white end of the strand on the black end once, and then reverse direction and do the other half reef knot. In the surgeon's knot, the slight modification is that you wrap one end on the other twice rather than once, and this forms the first half reef knot. And then you reverse the direction and do the usual half reef knot with a single wrapping, and you end up with the white ends coming below the black and the black ends coming above the white loop, much the same like a square knot. This adds to the security of the knot, the double wrapping and the first half reef knot. And this is how different knots have been modified. You can change the number of the wrapping in the first half reef or the second half reef, or have multiple half reefs, 2 or 3, like when you're tying synthetic material, for example. The basic idea remains the same. You are forming multiple half reef knots, whether by single wrapping or double wrapping, and then you could develop different types of knots. The idea behind developing the surgeons or the friction knot is that if you want to add to the security of the first half reef knot in the wound before applying the second locking half reef knot. So if you are using synthetic materials, you don't want the tension in the half reef knot to loosen before you apply the second half reef knot, and for this you wrap the suture twice before you start doing the other half reef knot. This adds to the friction and the security of the first half reef knot, particularly with synthetic material. And here is another simple modification of the first half reef knot that produces a different knot with different properties. In this slight modification, what happens is, if you have one end of the suture strand straight taut, like the white end is straight taut, for example in a deep cavity, you wrap the other end of the suture, the black end, over the straight white end, first above then below, but then you reverse and make it below and above, and by this you produce the first half reef knot, which slides well across the straight suture. And at the end you would want to secure the knot by interlocking the other two types in the different directions so as to form a secure knot. This is the type of knot that you use if you want to move a knot by sliding across a straight tooth end in deep structures like cavities, or if you're doing tonsillectomy, for example. And of course you can make any number required of half reef knots rather than two half reef knots in the square or the surgical sutures. You can triple it or quadruple it, and this is something you do if you are using synthetic materials to add more friction and more security to the knot. Mind you, by doing this you add up the bulk of the suture material that would be left in the wound. Which type of a knot is required for this particular task will depend on several factors. Top of the list is the material of the suture used. If it is synthetic, then you need to put on more throws. If it is if it's natural, and if it is monofilament, then you also need to put on more knots than if it is multifilament. This also, the type of the knot will also depend on the depth of the wound and its location, the expected stress on the suture line and the knot, and of course the risk of loosening of the knot, because if you are placing a knot on a named blood vessel, you want to add more security. Multifilament type of sutures that are either braided or twisted, like silk or vicryl, handles more easily and also ties more securely. The friction produced by the multifilament type of sutures increases the security of the knot, doesn't slip easily. On the other hand, the monofilament sutures requires more care during knotting for two reasons. The lowered friction of the monofilament sutures may allow the knot to slip. The other is the memory property of the monofilament synthetic material like proline and monocrylene nylon. They tend to revert to their original shape and position. That's why more throws are required in the knot, perhaps 5 or more, in order to secure the knot position. Sutures can be knotted either manually or by the use of instruments. If it's done manually, either by the use of the single-handed technique or the double-handed techniques, the surgeon has usually developed a certain sensation that signals that the knot is secured in position. It's a sensation of when the suture extends a little bit by stretching and then recovers when the knot is set and snugged down. This sensation alerts the surgeon that the knot is now secure enough. Using instruments like needle holders to knot sutures depend on the same idea, like doing it manually, with a slight modification. This time you are wrapping the one end of the suture, the long end, over a needle holder. So you actually wrap it either once if you're doing a square knot, or you wrap it twice if you're doing a surgeon's knot, and then you pick up the other end of the suture. In this example it's the short end, and pull it through the loops, the already formed loops around the needle holder, and this will give you the first half reef knot. And then you reverse direction and do the other half reef knot to end up with a secure suture. So rather than wrapping the two ends on each other directly, you wrap one end over the instrument and then pull the other end through the loops. So this is how the instrument tie is built up. You wrap the long end on the needle holder once or twice or any number of times required. You pick up the other end, the short end, and pull it through the open loops and form the half reef, the first half reef knot, and then reverse your hand and do the other half reef knot and secure the knot in position. There are about a dozen of general principles to produce a secure and reliable knot in the sutures. The first of them, of course, is the appropriate tension in the knot. If it is too low, then the knot may slip, but if it's too excessive, you may risk breakage of the suture itself or damage to the surrounding tissues. So knots should be just firm enough, and they also should be as simple as possible. Choose the least number of wrappings in a single half reef and the minimum number of half reefs to produce a secure knot, the simplest and the smallest knot possible to give a firm knotting of the suture line without adding too much bulk to the knot itself. And also the ends of the suture should be cut short after finishing the knot to prevent adding further bulk and foreign body material, particularly in buried sutures. The loose ends of the suture after it's being knotted can cause enough friction to loosen the knot. So that's why they should be cut as short as possible. Avoid applying instruments like a needle holder and certainly a hemostat on the first half reef knot that you have formed while you are trying to carry out the second half reef knot to secure the knot in position. If you have doubts about the security of the first half reef knot, add more wrapping rather than doing a square knot to do a surgeon knot, or add more wrapping in the first half reef to increase the friction and secure the knot while the second half reef is being tied. And the judgment of the amount of tension required is something surgeons develop by experience, but with experience, if you can use just the required tension to secure the knots in position, you can gradually start to use finer suture line that would also decrease the bulk of the suture material inside the wound. Excessive tension can cause, of course, strangulation of the tissue after the knot is being tied. Appropriate tension should be maintained on the suture ends while after placing the first half reef knot while you are doing the second half reef knot. Otherwise you risk loosening of the first half reef. This is best applied in the direction of the knot itself, like as horizontally or flat as possible. If force is applied in a vertical direction or diagonal direction, it tends to loosen the knot more and also risk pulling out of the tissues the knot has been applied to. And if a change in the surgeon's position or the hand's direction is required, then don't hesitate in doing this in order to apply the best possible direction of force that maintains tension while the suture is being tightened. Knots on sutures placed under the surface of the tissues, whether it is the skin or other viscera, should be buried away from the surface to prevent extrusion, the risk of extrusion or stitch sinuses and wound infection. And this is achieved by reversing the direction of the suturing, so that you end up with the knot on the deeper side of the surface rather than the superficial side. So you do it the upside down way. When a knot is being tied in a deep cavity like the tonsils, oral cavity, it's important to keep tension on both ends of the suture strands while the knot is being secured. It's easy to apply the tension on the superficial strand, but the trick is to apply equal tension on the deeper strand while the first half reef knot is being secured. This can be achieved by either an instrument like a knot pusher or a knot tie, or some surgeons can do this manually while the other strand is being pulled to snug the knot in place. If you are placing knots on sutures on named blood vessels, big blood vessels that deserve a name, then appropriate suture width should be selected for this, at least an 0.2 millimeters 3/0 suture, or if you are placing the suture on a tissue pedicle, then thicker sutures like 0.35 millimeters, the 0 sutures should be used. And of course, a triple throw is also appropriate when you are placing the knot rather than just the double throws of the standard square suture or the surgical suture. Knotting sutures while working in cavities either endoscopically or microscopically. The sutures can be knotted outside the cavity and then pushed inside by the use of a trocar or a scope, like extracorporeal knotting, or it can be performed inside the cavity itself if finer instruments are used. You usually use a very shallow needle like a 2/8 or a 3/8 needle, and then try and suture and knot the sutures inside the cavity itself. Once the knot is secured in position, you would want to cut the sutures quite close to the knot to avoid leaving unnecessary extra bulk of foreign body in the wound. Except perhaps if you are using gut sutures, then you want to leave about 6 millimeters of the sutures above the knot, due to the capillarity of the gut suture that can loosen the knot if shorter strands are left. You would be using usually a scissors tip to cut the sutures, and it can be helpful if you twist or angle the tip of the scissors in order to have the knot inside while you're applying the force to avoid cutting into the knot itself, and then the cut ends of the sutures will be removed from the operative site. By this we come to the end on this presentation on surgical knots. We proceed in the next presentations on different suturing techniques, including techniques to avert, invert, or apply or disperse tension on suture lines, or suturing special body tissues. Assalamu alaikum.